Hello to everyone around the world. We're going to give a few seconds or a minute just to let everyone actually get into the session. We'll start in just a minute. All right, I think that should be enough time. It is my great pleasure to welcome all of you to today's presentation on severe Epstein-Barr virus disease and the prospect of preventing EBV infection. And we will get started. I have a few housekeeping slides to go through before we get started, but most of you are members, and so you know about the Histiocyte Society, but remember that we're a nonprofit group of over 200 physicians and scientists from around the globe. We are all committed to advancing knowledge and improving outcomes for patients with histiocytic disorders. We have a big focus on clinical and basic research and education, and the HLH Steering Committee is proudly presenting this session today. Next slide, Kathy. Please remember that if you're a participant, you are muted, so you will not be able to speak during the presentation or afterwards today. You can submit general comments in the chat feature, and I do encourage you to reach out and just say hi to everyone and to all of your friends and colleagues today. The chat controls, are at the bottom of your screen, and if you have any issues, you can always text one of your friends to get some help with it. Next screen. For questions, and I know it's hard. I know some questions will end up in the chat anyway, but please, if you can, put your questions in the Q&A box. All the questions will be addressed at the end of the lecture. If you have a question, most likely it's for Dr. Cohen, but if you have a question for someone who's on the virtual audience who has expertise in a particular area, you can also address a particular question to them, and they can also answer in the answer boxes or in the chat. You can like a question in the Q&A box so that if you see a question that you're also dying to ask, like it, and it will move up the list. And we will do our best to get to all of the questions today. But as you know, we usually get so many questions that we always have a few that we don't typically get to. Dr. Cohen is kind enough that he's already offered that if you had a question that wasn't answered today, please send him an email. He's perfectly happy to send you an email response. Next. Don't forget, if you're not a member, you can become a member. And we're going to show that screen at the end of the presentation too. If you have friends, we encourage you to encourage your friends to join. So without any further ado, it is my very great pleasure to introduce Dr. Jeff Cohen today. Many of you know him and his incredible work, but for those of you who don't, Jeff is the chief of both the Laboratory of Infectious Diseases and the Medical Virology section, I'm sorry, I am having trouble speaking today, within NIAID at the NIH. Jeff has dedicated much of his career to understanding the pathogenesis of human herpes viruses, most notably EBV, including developing preventative treatments such as vaccines and monoclonal antibodies, identifying genetic changes which convey predisposition to severe disease, and just understanding disease. His work has led to nearly 500 publications, and we are so incredibly honored that he's taken the time to join our last Histiocyte Society webinar of this academic year. Today, Jeff is going to share his EBV expertise with us and also tell us about his lab's groundbreaking work towards prevention of EBV infection and disease, which obviously all of us care about a great deal. And with that, Jeff, I will turn it over to you. Thank you again.
Well, thanks so much for the kind invitation, and I really appreciate it. And of course, I always love to talk about EBV. So Epstein-Barr virus is associated with a number of different disorders. There are about 125,000 cases of infectious mononucleosis each year in the United States. Very rarely, but some of these individuals do develop EBV-associated HLH. More importantly, or EBV is associated with about 200,000 cases of cancer each year. And it's associated with both epithelial cell cancers like nasopharyngeal carcinoma, and about 8% of gastric carcinomas are EBV positive, but also associated with a number of lymphomas, Hodgkin's disease, Burkitt lymphoma, and non-Hodgkin's lymphoma. We also see EBV in individuals with lymphoproliferative disease or lymphoma who have primary immunodeficiencies. And importantly, in these diseases, as I'll talk about, the virus is in B cells, as it is in most of us who are infected with EBV. The virus also is associated with post-transplant lymphoproliferative disease. And in my clinic, I see a number of individuals with a very unusual disease, which I'll also talk about today because it's associated with HLH, chronic active Epstein-Barr virus disease. In contrast to the other diseases shown here, the virus is present in T or NK cells as opposed to B cells with chronic active EBV. And then more recently, there was a paper last year in Science stating that EBV was a cofactor or a potential cause for multiple sclerosis, and that sort of heated up the EBV field quite a bit. So I'm going to first talk about chronic active Epstein-Barr virus disease, a very rare disorder. And we define chronic active EBV disease as chronic, meaning it has to be a progressive illness for 3 months or more. These individuals have very high levels of Epstein-Barr virus DNA in their blood by PCR, usually greater than 100,000 copies in whole blood. And these individuals have, by definition, we require a pathologic diagnosis of infiltration of tissues with either EBV positive T cells or NK cells. And they can't have another known immunodeficiency, particularly HIV or other immunodeficiencies. So chronic active EBV disease has a very poor prognosis in the absence of stem cell transplant. These individuals typically go on to develop fulminant liver failure due to EBV infiltrating T cells or NK cells in the liver, or they develop HLH, or they develop T or NK cell lymphomas. This disease is much more common in Asia and Central and South America and relatively rare in the US. And as I alluded to before, it's refractory to antiviral therapy or immunomodulator therapy. And although cytotoxic chemotherapy can sort of take the edge off of things and temporarily help, these people are not cured unless they undergo a stem cell transplant. So unlike natural infection, EBV infects T cells or NK cells in patients with chronic active EBV. Germline mutations are very rarely identified in this disorder, and I only know of a couple, just literally less than a handful of cases where germline mutations have been identified. In the past, we used to call chronic active EBV a disease of B or T or NK cells, but in the new nomenclature that just came out, it's no longer considered chronic active EBV if the virus is in B cells. And that's because many of the patients that I used to see with B cell chronic active EBV, now that we do whole exome sequencing, many of them have been found to have mutations in the germline, resulting in genes that are important for immunosurveillance. So people that we used to call B cell chronic active EBV, we found had mutations in perforin, syntaxin binding protein, et cetera. Patients with T cell chronic active EBV often have T cell clones in the blood. And in Japan, there was a paper in Nature Microbiology where they did a large study doing whole exome sequencing of the patient as well as the patient's T cells or NK cells. And they found somatic mutations in some of the T or NK cell patients in just the EBV infected T or NK cells. And these were in cancer driving mutations like DDX3X and other genes shown here, not in the genes we associate with impaired immune surveillance or immunodeficiency. Some of these same somatic mutations found in chronic active EBV were also found in T cell leukemia or T and NK cell lymphomas. So this disease is not really an immunodeficiency disease. It's more of a disease where one has somatic mutations in the T or NK cell that's infected with EBV. And it's a very different disorder than the immunodeficiencies. The differential diagnosis, what I think about when I'm concerned about chronic active EBV, particularly in people with very high EBV viral loads. Some of them, again, have EBV-associated primary immunodeficiencies, but again, the EBV is in the B cells in those patients, not in the T and NK cells with chronic active EBV. Some patients have primary infection with EBV, with or without EBV-associated hemophagus HLH and other findings. And those people with primary infection can have EBV in B or T or NK cells. But again, this is sort of an acute infection, not chronic of the chronic active EBV, not 3 months or more. So we've been fooled. We've seen people with a month of EBV and T cells, very severe disease that we treat for HLH, and everything goes away, and they are cured, and they don't have this chronic active EBV problem. And I'll talk about that in a little bit. Some people have EBV-associated acquired immunodeficiencies or EBV malignancies, which are not necessarily chronic active EBV. And then I also see patients with this unusual disease called hydrovacciniform lymphoproliferative disease. These people have EBV in their T and NK cells. They have high viral loads in the millions, but they do not have, and they'll have skin disease that will have EBV in it, which will be driven by solar radiation. So it'll be on the face or sometimes the hands. But if many of those individuals do fine, particularly if they're Caucasian, and they don't go on to develop chronic active EBV. Some of the other ones who have different ethnicities can go on to develop chronic active EBV. So this is also in the differential diagnosis and often is different than chronic active EBV. So how do we treat this disorder? Well, prior to transplant, we try to preserve their organ function, particularly their liver function, so that the risk of transplant is reduced. And we don't obsess about the viral load particularly, because a successful transplant will resolve the EBV. So I'm often called by people who say, well, we need to get the viral load down before we can transplant the patient. And that's not what we want to do. We want to preserve their organ function and then try to go to transplant right away and not worry about the viral load, because again, the transplant will take care of that. Some patients are very toxic. They have high fevers, they have organ disease, and before transplant, sometimes we can reduce the toxicity by steroids, bortezomib with ganciclovir, or romidepsin with ganciclovir, which can induce viral replication. The ganciclovir will get phosphorylated in those cells that have expressed the viral TK, protein kinase, and kill the cells. So these are sort of temporary things along with chemotherapy that can help to sort of reduce toxicity of the patients. And of course, if they have HLH, we treat the HLH because that is really a life-threatening, rate-limiting step here. Over the years, some of the patients that we've heard about have been treated with alemtuzumab or Campath, and those patients have done very poorly unless they're about to get a transplant right away. This drug reduces or eliminates any remaining virus-specific T cells, and the chronic active EBV can blast off. So unless they're about to get conditioning, we don't recommend alemtuzumab for these individuals. So the largest studies really have come from Japan, and they found an 87% 3-year event-free survival and overall survival, and in studies, 91% overall survival with reduced intensity conditioning versus myeloablative therapy. So now we try to do reduced intensity conditioning on our patients. And you can see if patients just get chemotherapy, unfortunately, they all died. Those who got stem cell transplants did reasonably well. Those who were delayed to some extent by getting chemotherapy didn't do as well. And many of these patients were much more toxic or had more organ disease, which is why perhaps they didn't do as well to begin with. Older patients have a poorer prognosis. Elderly here was defined as greater than 45, which I think not necessarily so elderly, but regardless, individuals who were children or adolescents had a much better survival than those who were over 45. Importantly, most of the deaths in patients who are transplanted were due to relapses. So we did a retrospective study from 25 medical centers across the United States, and actually outside of the United States as well, but not in Asia, because that's where the disease is more common. We were able to scrounge up 57 patients with chronic active EBV, 93% from the United States. The mean age of the diagnosis was 14, slightly female predominance. And even though none of these patients were from Asia, about 50% were either Hispanic or Asian, 35% were white, 12% were Native Americans. And again, a lot of EBV diseases like nasopharyngeal carcinoma and tonsillar carcinoma associated with EBV are much more common in Native Americans or Inuits or individuals from Alaska or Northern Canada. So they're sort of disproportionately represented as well with chronic active EBV. Patients had EBV involving T cells or NK cells. And again, the viral load was very high at diagnosis, 5 million copies per mil, and that's the median value. HLH, which you guys are all interested in, was present in 58% of the individuals with chronic active EBV. You can see about 80% had cytopenias and 40% had lymphomas. Importantly, relapsed or refractory HLH was common in the cohort, and almost a third of them who developed HLH ultimately died from the disease. And relapse after stem cell transplant was frequently associated with HLH. So this is a major issue with chronic active EBV. In our study, people who did not get transplanted all passed away. And you can see here that the median survival was 52 months in our individuals, not as good as what was seen in the group from Japan. Going in the wrong direction here. So to summarize our study, which is the largest cohort of individuals outside of Asia, most had T cell chronic active EBV, compared to in Asia, it's more 50% T cell, 50% NK cell. We didn't see any difference in survival in T or NK cell, but the folks in Asia report NK cell has a better prognosis. Our survival was not as good as what was seen in Asia, and probably because in Asia they're more often used to seeing this disease, and they get referred much more quickly to transplant. Our patients, unfortunately, take longer to be recognized with chronic active EBV, and as a result, we think survival is not quite as good. Most of the deaths were in our study were frequently due to HLH. Less common were sepsis and thrombotic microangiopathy. Survival after transplant was about 50%, as I mentioned, less good as in the Asian studies. And again, disease control is more important than viral load control if you see somebody with this disorder. Earlier transplant and aggressive management of EBV after transplant is very important in terms of trying to reduce the risk of relapses. So I'm going to move on probably to some genetic disorders that you are as familiar or more familiar with than I am. And we think about EBV and HLH with a number of different genetic disorders, FH, the familial hemophagocytic lymphohistiocytosis 2, 3, and 4. These are the genes associated with them. And of course, this work actually comes from a paper that Dr. Marsh wrote just a few years ago. One can screen for these with by looking at perforin expression or CD107A. And then there's some more EBV-specific disorders, XLP1 and XLP2, that are associated with mutations in SH2D1A or the SAP protein or XIAP. And then there's some other EBV-specific disorders which are less commonly associated with HLH, but HLH still can occur, CD27, ITK, and MAGT1. And again, there are different ways to screen for these. So one of the questions is, what do these things have in common, and why would they be associated with HLH? So there's sort of three factors that I think sort of put those genes in common, why they might be associated with HLH. And you all are familiar with the familial forms are associated with defects in granule maturation, degranulation, or in perforin. So those are sort of the classic things. some of the EBV-associated disorders associated with HLH are important for the connections between EBV-infected B cells and cytotoxic T cells. So XLP1 or SAP is important for regulation of 2B4, CD48, which are important for interactions between cytotoxic Ts and EBV-infected B cells. CD27, which is on that list, interacts with CD7, again, important for this interaction here. And XMEN is associated with impairment of NKG2D, which interacts with its ligand, again, for the interaction with cytotoxic T cells and EBV-infected B cells. And we think this T cell EBV-infected B cells, and particularly the B cells here, is why we see problems with EBV and less so with other viral infections, because EBV is really the only virus that infects and can cause potentially transformation of B cells. There's some other genes also associated with HLH, XLP2 and ITK, and these are important, of course, for T cell signaling. So we think that, granule maturation, degranulation, B and T cell interactions, and T cell signaling are what these many different genes have in common. So I'm going to present a patient here that we saw a number of years ago, a 3-year-old girl who presented with fever for 10 days and then actually went into shock and multi-organ failure. She was admitted to the hospital with pancytopenia, hepatosplenomegaly, elevated transaminases, triglycerides, elevated ferritin, and soluble IL-2 receptor, and met the definition for HLH. She had atypical lymphocytes, an EBV viral load of over 2 million. A bone marrow showed erythrophagocytosis with EBV and T cells and oligoclonal T cells. And so she clearly had HLH, and many of us were concerned whether she had chronic active EBV, and is she going to need a transplant? She was treated with HLH, shown here. She got acyclovir and bortezomib. Her whole exome sequencing showed no pathogenic variants, and after just HLH therapy alone, her viral load went back down to undetectable. Her blood counts were normal, and she did very well without any additional therapy, and she's 9 years after presentation now. So not all high viral loads with EBV, HLH, not all of this is due to familial HLH or chronic active EBV or genetic disorders. Some people just present with just horrible primary EBV infections and HLH. In this patient, the biopsy showed lots and lots of EBV positive cells that encode EBV RNA, and they are. You can also see that they sort of are present also with T cells in the tissues here, but the tissues had very rare B cells. So again, chronic active EBV, the important word is chronic, because again, you don't want to confuse that for these acute EBV infections, because both of them have HLH. So we say people have to have disease for 3 months or more and are not cured with HLH therapy alone. In our study, about 1/3 of the patients with chronic active EBV had HLH. In contrast, we sometimes see people with just horrendous primary EBV infection with HLH. And again, in Japan, they see this more often. They did a nationwide survey of HLH in Japan, 98 children less than 18 years old. 97% with acute EBV infection HLH had EBV and T or NK cells, very high viral load. 2/3 of them were put on an HLH protocol, and of the 98 children, 9 of them didn't respond to the HLH therapy, and 8 of 9 died. They probably did have genetic disorders, but more importantly, 89 out of the 98 did very well with HLH alone. You can see the overall survival was well over 90%, and progression-free survival was 80% or more. So when you think about some young child with a horrible EBV disorder and HLH, some of them don't have genetic disorders. Some of them just have, primary EBV infection. And, how might that work? Well, let me go over before I do that. We treat HLH, as you probably all know, with, we tend to use the HLH 1994 protocol without cyclosporin, which of course can be associated with press and hypertension. We sort of are conventional using the HLH 1994 protocol. We are very interested to know whether EBV is in B cells, which might be more of an immunodeficiency as opposed to T cells. And if it's in B cells, of course, we add rituximab. We monitor for PCR, for DNA EBV PCR, ferritin, soluble IL-2 receptor, more recently CXCL9 and HLA-DR. We try to evaluate quickly for a genetic cause, and we do some of the screening, as I mentioned from Dr. Marsh's paper, CD107A, perforin, and other things. And then transplant is recommended if people have CNS involvement, recurrent or refractory disease, or HLH with clear mutations in pathogenic that are pathogenic associated with these genes that I mentioned before, or compound heterozygous. And as I mentioned, reduced conditioning may improve the outcome. There are other approaches, ATG and methylprednisolone, the hybrid immunotherapy protocols, and then for refractory individuals, emapalumab, monoclonal antibody interferon gamma with dexamethasone has saved some individuals. Obviously, it's very, very expensive. And then a review done by the Histocyte Society Salvage Therapy Working Group showed that 4 particular avenues of treatment, anakinra, ATG, alemtuzumab, and DEP chemotherapy seem to be associated with effectiveness for refractory disease. Other things that are tried are anakinumab, canakinumab, etanercept, TNF inhibitors, or jakinibs, or tocilizumab. So there are a number of different things that can be used for refractory therapy. So to summarize this portion of the talk, we see different types of EBV diseases in HLH. We see primary HLH due to the genes that you guys are very familiar with, along with some EBV-specific genetic disorders shown here. Many of these individuals, but not all, will have a strong family history of EBV lymphoma or EBV HLH. Unlike the secondary things, here the EBV is in B cells, so we spent a lot of time trying to figure out whether EBV is in B cells or T cells. And treatment for this involves obviously treating the HLH, and if it's a genetic disorder, typically they require stem cell transplant. And because it's in B cells, we can treat with rituximab. In contrast, we see secondary HLH. That can be due to an acute EBV infection, like the little girl that I mentioned, with no known genetic disorders, or they can have chronic active EBV, again, 3 months or longer, as opposed to this acute process, with no germline mutations, but some of them have been shown to have somatic mutations. Again, these individuals have T or NK cell disease as opposed to B cell disease. We have to treat the HLH, which is going to be the rate limiting step that has to be, they have to be cooled off with HLH therapy. And then the acute individuals, acute primary infections, usually have long-term remissions and do very, very well. Those with chronic active EBV, 3 months or more, require a transplant. So, in my clinic, we try to figure out whether the virus is in B cells or T cells. Typically, we'll look at a biopsy or a bone marrow and have a pathologist stain for EBV by EBR staining, which is an in situ hybridization for EBV. And their lab can sometimes do co-staining for both EBR and CD20, CD3, CD56 to see whether these EBR positive cells are in the same cells, or they can look at adjacent sections. And if there's a ton of EBV in the tissue, you can sort of see whether it seems to co-localize with B cells or T cells. Alternatively, if that is equivocal, sometimes we will take peripheral blood, sort it into B cells, T cells, and NK cells, and take those 3 different populations and do EBV quantitative PCR. on the B, T, or NK cells and see which population has the most EBV, because again, that can tell us about rituximab, whether the patient falls in this category or falls in this category. So I, in addition to doing all the other things, really like to focus on what type of cell type is the EBV in. So that is part one. And part two, I'm going to talk about our lab's efforts to try to prevent EBV infection or prevent EBV or treat EBV disease. And this is really a true work in progress. So we have been working on a EBV vaccine. Obviously, if we could prevent EBV infection, we wouldn't have to deal with all those things in the first part of the talk. We might not be able to prevent infection, but we might be able to reduce the initial infection and again, potentially reduce some of these EBV diseases. So when the virus enters B cells, it has a number of glycoproteins on its surface shown here. GP350 interacts with CD21, also known as CR2 or CD3, and that's important for the virus to attach to cells. The virus has 4 other glycoproteins shown here, and there's a complex of proteins shown here, GHGL, GP42. GP42 binds to a receptor, HLA class 2. And when that happens, it activates GB, and probably from its pre to the post-fusion form, and initiates fusion of the virus membrane to the cell membrane. So attachment is virtually essential for the virus to bind to cells. Fusion is absolutely essential. And as a result, these glycoproteins have all been targeted for EBV vaccines. Now, the virus, of course, initially enters most of us through the oropharynx, and the virus can bind to epithelial cells in the oropharynx. And instead of GP350, there's another protein that's important for attachment to epithelial cells. And instead of this trimolecular complex, it's just GHGL without GP42 to activate GB for fusion. So again, we think about these proteins for vaccine development. So the vaccine that's furthest along in clinical trials thus far is to GP350, this attachment protein. As I mentioned, it binds to a protein called CR2 on B cells, allows the virus to get absorbed inside those B cells. It's the major target for neutralizing antibodies. If we look at IVIG, for instance, and what are the major neutralizing antibodies against EBV, about 50 to 60% are targeted to GP350. It's also a target for ADCC and for a target for T cell, CD4 and CD8 T cells. So for all these reasons, until very recently, companies had focused on GP350 as a target for a vaccine. And the only phase 2 study published to date for EBV for a vaccine was a soluble EBV GP350 vaccine. This was done in a double-blind, placebo-controlled trial in Belgium. 90 individuals got vaccine, shown in black here. 91 got placebo, shown in white. They got 3 doses of the vaccine, shown by the arrows here. The vaccine was given in an alum. And the individuals that got the vaccine had a reduced rate of mono relative to those who got the vaccine. I'm sorry, that relative to placebo. And the vaccine reduced the rate of mono by 78%, but it did not reduce the rate of EBV infection. So with that, the company GSK, who had developed this vaccine, dropped it and did not do any further development because it did not prevent mononucleosis. Not prevent EBV infection, and prevented a reduced mononucleosis in a phase 2 study. So we decided to see if we could improve upon this vaccine, soluble GP350. And we, instead of using soluble GP350, we decided to use what's called a nanoparticle, which is a multivalent, symmetrical, repetitive array of antigen on a particle. So you may know that the hepatitis B virus vaccine is a particle with multiple copies of the hepatitis B surface antigen. And the HPV vaccine, human papillomavirus vaccine, is a particle with multiple copies of one of the proteins of HPV on it. And by having these particles with a dense array, it cross-links B cell receptors very effectively, and you get very high antibody titers. So we hooked up Helicobacter ferritin, a prokaryotic or bacterial ferritin, with GP350. And each of these little red balls is where the GP350 would be attached to this ferritin. When you transfect this single plasmid into cells that has ferritin infused to GP350, the cells secrete a nanoparticle because ferritin self-assembles. And we did this by collaborating with the Vaccine Research Center, NIH, who had previously made an influenza HA ferritin and shown that it induced high titers and broadly neutralizing antibodies in mice. So again, GP350 is shown here. The GP350 that was used in the vaccine trial was virtually identical to this, although we put a his tag on, and before it went into people, the vaccine trial, that phase 2 study, did not have a his tag on it. We made multiple constructs fused to ferritin. The one that worked the best had the first 3 domains of GP350 fused to ferritin. And when we transfect cells with either empty ferritin alone, you get the spherical particle, but you can see here the GP350 radiating off from the ferritin molecule shown here. So we took this vaccine and compared it to the soluble vaccine. Again, this was almost identical to what was used in that human trial. And we showed in mice, at least, the ferritin vaccine induces much higher titers of neutralizing antibody. This is a log scale, so we're talking about like 100-fold higher levels of neutralizing antibody with these nanoparticle as opposed to the soluble protein. And in monkeys who have an EBV homologue called lymphocryptovirus, they're getting a boost with the ferritin molecule that's higher than the boost they get with soluble GP350. So why might that vaccine be better? That is the nanoparticle and the soluble GP350. Well, as I mentioned, when you have an antigen in a nanoparticle and the distance between the antigen binding sites or receptor binding sites, so this is GP350. It's a cryo-EM model done by the late Michael Rossman's group that we collaborated with. The receptor binding site on GP350 is CR2, and this receptor binding site is 50 to 100 angstroms apart, which is the distance to cross-link B cell receptors. So we think by having this distance optimized, we're getting much better antibody responses to this nanoparticle than to the soluble G350 vaccine. So with that in mind, we were able to get our GP350 nanoparticle produced under GMP conditions. And we've initiated a clinical trial at the NIH with this GP350 nanoparticle. We have 20 seronegatives and 20 seropositive volunteers, 18 to 29 years old, that are getting 3 doses of this GP350 nanoparticle vaccine. We tested multiple different adjuvants in non-human primates, and Matrix M, which is a saponin-containing adjuvant, seemed to work the best. So that's what our vaccine is adjuvant in. We're giving it 0, 1, and 6 months, almost the same time points as that GP350 soluble trial that I mentioned. And we're doing a 1-year follow-up. Our primary endpoints in any phase 1 study is safety, but we're also looking at changes in the neutralizing antibody levels along with T-cell responses and numerous other secondary endpoints. All I can tell you is that we've enrolled about 30 individuals so far. We haven't seen any safety signals, and we'll be looking at the immunogenicity data very soon. But we're very excited to have that vaccine in clinical trials. Now, as I mentioned, in addition to GP350, there are other glycoproteins that are important for entry of virus into cells. So Wei Bu in my lab took IVIG, which of course is pooled from over 1,500 donors, and depleted the GP350 antibody from IVIG and looked to see how much neutralizing antibody was still left. And about 50 to 60% of neutralizing antibody was still left, meaning that some of that neutralizing antibody was directed against other glycoproteins. He also depleted GHGL, and that contributed about 20 to 30% neutralizing antibody, depleted GP42. And you can see is that if you just deplete all 3 of these antibodies to all 3 of these glycoproteins, they're responsible for about 80 to 100% of the neutralizing antibody for B cells and about 70 to 80% of antibody for epithelial cell neutralization. So we think even a better vaccine would be one that had GP350 and GHGL and GP42 that could not only improve neutralizing antibody against B cells, but also allow neutralizing antibody against epithelial cells, because GP350 is not important for epithelial cells, but GHGL contributes about 75 to 80%. So with that in mind, we went ahead and made a GHGL GP42 nanoparticle vaccine. Here we transfect cells with GH fused to ferritin along with GL and GP42. So all three of these plasmids are put into a cell, and GL and GP42 have a strong association with GH. And what gets secreted from the cells are nanoparticles. If we just put these two plasmids in, they're GHGL nanoparticles. So we put all three of these in, they're GHGL GP42 nanoparticles. And if we test these in, here we're testing these in non-human primates, the trimeric nanoparticles, GHGL GP42 ferritin, outperform the soluble nanoparticles in terms of neutralizing B cell infection or neutralizing epithelial cell infection. And our ultimate goal would be to combine the two together, the GHGL nanoparticles with the GP350 nanoparticles. And in mice, if you give these individually or in combination, you get very good neutralizing antibodies in B cells, very slightly higher, about threefold higher. Again, this is a log scale if you combine them together. But again, if you have the GHGL GP42 nanoparticles either alone or with the GP350 ferritin, you get much better neutralizing epithelial cell titers. So I think in the interest of time, I'm actually going to skip over this slide, but it shows that, it shows that if you immunize mice with these nanoparticles, collect serum from the immunized mice, and then give them to naive humanized mice, and then challenge the humanized mice with EBV. So you're passively transferring antibody from these immunized mice and challenging with EBV. The serum from animals that got these vaccines protected the animals from viremia, as opposed to the control animals that all became viremic. I'm going to skip over this. And when we look at those animals that got challenged with EBV, the ones that got serum from control mice, about 50% of them got EBV lymphomas. The ones that got serum from the vaccinated animals, either of these vaccines, none of them developed EBV lymphomas. So this vaccine, if it's given, before challenge with EBV, actually protected mice from EBV lymphomas, which was very exciting to us. So Moderna has recently started a phase 1 trial of mRNA, which it's mRNA to GP350, GHGL, and GP42, all four of these mRNAs given a single shot to try to control EBV infection. And our nanoparticle vaccine has been produced, and we are planning to do a study the first quarter of 2024 of the GP350 and GHGL GP42 nanoparticle. So what might we use the vaccine for? Well, we might be able to prevent mononucleosis, like was found with the soluble GP350. Importantly, we might be able to prevent post-transplant lymphoma in seronegative individuals that are going to get a transplant. We see individuals with X-linked lymphoproliferative disease or other genetic disorders, and if they can respond appropriately to a vaccine, that might prevent EBV disease if they get infected. There's been a big push now by companies to think about EBV vaccines that might prevent multiple sclerosis or lymphomas or nasopharyngeal carcinoma. An EBV vaccine might not induce sterilizing immunity, but a vaccine that blocks infection of B cells and epithelial cells might result in a lower viral load to reduce EBV diseases. So highly immunocompromised patients might not respond to an EBV vaccine, and seronegative transplant recipients have a much higher rate of developing post-transplant lymphoma. So monoclonal antibodies given might reduce the rate of lymphoma after transplant in these seronegative individuals and might reduce EBV disease. You can sort of think of this like COVID. You know, you either get a vaccine if you're highly immunocompromised and you're not going to respond to a vaccine. Well, getting monoclonal antibodies might be useful. So persons with immunodeficiencies at high rate of fatal EBV disease, some of them have been given IVIG, but breakthroughs have occurred. Again, the antibody titers for EBV may not be great. So with that in mind, we've gone ahead and made monoclonal antibodies to GP350, GHGL, and GP42. We've made multiple multiple antibodies to GHGL by isolating PBMCs from blood bank donors, sorting them into single cells, and then looking at which cells are secreting neutralizing antibody. And shown here are just 5 or 6 of the monoclonal antibodies. We've made many more than that. And the lower number of micrograms per mil to neutralize the virus, the better. So you can see that this B10 antibody is very potent in neutralizing B cells and epithelial cells, as shown here. And when we look at the top 3 candidates shown here, they all bind to different regions of GHGL when we did crystallography. We did our humanized mouse model, as I mentioned. Here we gave the mice 2 doses of monoclonal antibody before challenging with EBV. We gave them some doses afterwards. And the animals that got the most potent neutralizing antibody, B10, had the best survival. They had only one of the animals became viremic, as opposed to with the other antibodies. And none of the animals that got the B10 developed lymphoma, as opposed to some of the other animals did develop lymphoma. We've also made monoclonal antibodies to GP42, and A10 was the best monoclonal antibody. It actually binds to the same site where the GP42 binds to HLA. And again, this monoclonal antibody protects mice from dying from EBV. None of these mice actually had a viremia compared to the other antibodies. None of the mice that got the GP42 monoclonal antibody developed lymphoma or lymphoproliferative disease. So on the last slide, our soluble GP350 vaccine, I should say the clinical trial, it reduced EBV mononucleosis. This is the one that was done 17 years ago, but did not prevent infection. We think ferritin nanoparticle vaccines may be more effective than soluble GP350. Serum from the mice immunized with nanoparticle vaccines protected humanized mice from viremia and from lymphoma. The nanoparticle vaccine is in clinical trial along with Moderna's mRNA vaccines. And monoclonal antibodies neutralize infection. They protect humanized mice from death and viremia and lymphoma. And these monoclonals might be used to prevent EBV disease in transplant patients or immunocompromised patients. So actually the last slide, much of this work was done by a staff scientist, my group, along with a graduate student and postbacks. Dr. Durkee Schock runs the clinical trial, and this is a collaboration with the Vaccine Research Center. So I'm going to stop there, and if I haven't used up all my time, maybe we have about 10 minutes for questions.
We do.
Thanks.
We have about 10 minutes left. Oh my gosh, Jeff, that was so great. I'm going to turn it over to Shanz shortly to moderate the questions, but I have a really quick one. I was so impressed by the efficacy of just neutralizing antibody. I would have thought that maybe in patients, you would need some degree of T-cell response to the vaccine as well to really, prevent bad things from happening. But based on your data, do you feel, I'm guessing pretty confident that really, no, you really just need antibody?
So excellent question. To be totally honest and transparent, I have no idea what the correlate of protection from a protection of EBV is. We think of neutralizing antibody because that's the correlate of protection for many virus infections, but I would be naive to say that that's the definite correlate of protection. So just to sort of start out with something, we look at neutralizing antibody, but there's other activities, ADCC, ADCP, there's T cells. I tend to think to prevent infection or to prevent the initial initial interaction, antibody is going to be more important. But once you're infected with EBV, T cells are going to be more important. So I think for a preventative prophylactic vaccine, B cells or antibodies going to be more important. But for a therapeutic vaccine to try to prevent serious disease once you're already infected, I think Dr. Cohen's lab needs to start over with a therapeutic vaccine, and those would probably be to other antigens, proteins on the virus. So excellent question. So Moderna and the NIH is putting their eggs into the glycoprotein antibody basket, and we'll see what happens with that. So thanks for the reality check, Rebecca.
Thank you. Shannon, take it away.
Thank you, Jeff. This has been awesome. I learned a lot. I'm sure everyone in the audience learned a lot. There are several very interesting questions up in the question and answers section. The first one is, I think many might have already reached out to you for this. Does VST work in chronic active EBV?
Do virus-specific T cells work for chronic active EBV? We have used them in probably about a handful of patients, and they sometimes have temporized things a little bit. So we found that the viral load goes down. Sometimes the patients have reduced fever, but usually within a month or two, patients are as sick as they were beforehand. And we've never cured anybody with virus-specific T cells in this. There's another role for virus-specific T cells, and that is after transplant, if the viral load starts to creep up, one can give virus-specific T cells, and we've seen that, control the patient, and they have long-term successes. So sometimes we do consolidation sort of therapy with virus-specific T cells, but it has not cured the initial chronic active EBV in any of our patients, or any that I'm really aware of. And again, I think this is different than some of the other things, because again, I think this is a somatic mutation, or a sort of a tumor in those T cells that just virus-specific T cells is not going to control, unlike the PTLD. Go ahead.
Thank you. And because the relapse rate post-transplant with chronic active EBV is significant, there's another question about what conditioning do we typically use, and is there a role of rituximab during that process? I do have another question on that. On relapse, are we seeing the EBV get back to the T cell as a relapse disease, or is it because of inadequate conditioning and clearing of the disease, or is the donor T cells get infected with the EBV?
That was a lot of questions. I think so in terms of the conditioning, I have to be humble here and say that I'm an infectious disease physician, not a transplant physician, and I sort of leave the conditioning up to those individuals. And I'm not going to go into specific conditioning. Some of the papers we published have the conditioning regimens. Clearly, reduced intensity conditioning is good up front, because you're not subjecting people to such a horrendous conditioning regimen. On the other hand, you're somewhat increasing the risk of relapse because of that. And if you can get some sort of graft versus tumor effect, that'll reduce the rate of relapse. I don't think rituximab has a role in virus infection of T and NK cells, so we really don't use that. There's some other drugs like asparaginase that seems to be particularly helpful for some of these patients with chronic active EBV. Numbers are small. We don't have any, controlled studies with that. The relapses, again, are due to reactivation of EBV in the T cells, not in the B cells. I'd have to double check about whether it's in the donor cells or the recipient cells, to be perfectly honest. Yeah.
Thank you. And keeping on the theme of chronic active EBV, there is a question on the role of serologies. Is there a predictive value for EBNA?
Yeah. So people with chronic active EBV, many of them, for some reason, don't make antibody to the EBNA complex. But I don't think that that is particularly predictive. And again, I've moved, years ago, we used to do antibody tests by serial dilution and immunofluorescent assays, and those were much more quantitative than the ELISA assays that we have now in terms of correlating with things. So I really focus on EBV viral loads, and I think really looking at the level of EBV DNA in the peripheral blood is much more useful than looking at antibodies. So I don't really focus on antibody responses like I used to for chronic active EBV.
Scott is asking an interesting question. Are there differences we are seeing in Asia versus US? How much of this could be a strain difference in EBV versus something more inherently genetic wise? It's not a monogenic disease, but SNPs and polymorphism play.
Yeah. Excellent question. So there's been a very few studies really looking at strain differences, but again, most of us don't think it's strain differences because we don't see chronic active EBV running in families, and that also suggests it's not due to germline mutation. And if it was strain difference, I'd expect it to be run in families. So I think it's really more of more like a somatic mutation in these individuals. Why it occurs more common in Asians and Hispanics than people in the than whites, I don't know, but I don't think we know why NPC is more common in China necessarily than it is in other places. So I don't really think it's due to strain differences. Much of the work that's thought were strain differences for other diseases more common than chronic active EBV has generally not panned out, and some of the strain differences were more associated with geography. Certain strains are in different parts of the world, rather than the strains being more pathogenic than other strains.
Thank you. And Dr. Elaine Jaffe, going back to the acute EBV HLH setting, how much of this, the T cell process, is clonal? If I get the question right, especially she's referring to the Japanese study with acute EBV HLH, and were any of these cases clonal?
Yeah, I'd have to go back and look at that. And at that, I just don't remember from that paper by Kawa at all. I'd have to go back. And Lane, I'll be happy to email you later today with the answer. But a good question. And clonality is not, in my mind, clonality is not sort of a make or break for whether people have serious problems with EBV. Of course, we see PTLD in people with clonal disease and not clonal disease. I think it's sort of a predictor. It's useful to know, but I don't think it's, if it's not clonal, it doesn't mean you're out of the woods. Go ahead.
And we'll take one last question. So there is some data from China about the role of PD-1 inhibitors. I want to hear your experience and thoughts on what is the role of PD-1 inhibition in chronic active EBV.
Yeah, we've treated just a very few individuals with chronic active EBV with PD-1 inhibitors, and we're talking about, just like 3 or 4, a really small number. And to be honest, we have not seen much effect. The viral loads did not budge. The disease really did not budge. So I think, unfortunately, this disease does not respond terribly well to immunomodulation. As sort of I mentioned, we've tried many things, including immunomodulation for chronic active, and that has not worked. Now, whether PD-1 in combination with other things might work, but I think really still in 2023 we need transplant for this disease. But an excellent question. We've tried it. We thought of that too.
Maybe one last practical question. I think many have this in their mind, even your thought. Like if we get an EBV HLH, and you're in a center where you cannot sort EBV or may not have the immunohistory to do it, is it reasonable after 2 doses of rituximab, if you don't see a budge in EBV titers, do you assume this is a T cell disease, or is there any role to continue giving rituximab?
I think if after a few doses of rituximab and you don't see any budge, particularly in the viral load, well, I guess the issue would be if you can monitor the the B cells in the peripheral blood, and you show that the B cells in the peripheral blood, if you do a TBNK and show the B cells in the peripheral blood are gone, and yet the viral load is still high, to me that implies that the EBV is more likely in, not in B cells. So I think if they don't respond to rituximab, I can't, I never say never, but I think it's extremely likely that the virus is not going to be in B cells in those individuals.
Thank you so much. I know there are several more questions. I'll have Rebecca take it from here. Thank you.
Yes, thank you so much, Jeff. Really, there are such glowing comments and thank yous in the chat. To be respectful of time, I'm going to rush through this last bit. You will receive a survey if you are on the call today, so please fill it out. It helps us improve these sessions. Next slide, Kathy. Very important, don't forget our annual meeting is in Athens in October. Please sign up. We really want to see everyone in person there. And with that, I'm going to say thank you again so much, Jeff, and I'm going to let everyone go. I hope you enjoy the rest of your days and everyone take care.
Thank you.
Thank you.
Bye, guys.